Yes,
Uh,
sir.
yeah. So we are starting this today's program for MRA student. Uh, Prasad, please mute everyone. Uh, so, so today we have a case presenter, Dr. Keyur, who is from Hinduja, and we have two great moderators, Dr. Isha Sood, ma'am, who has done MD Medicine and DNB Rheumatology. She did her DNB Rheumatology from Indraprasth Apollo Hospital, New Delhi, and she has various 20 publications on various national and international journals. Right now, she is practicing at Mumbai. We have another moderator, Dr. Vaibhavi Velangi, who has done her DNB clinical immunology and rheumatology from the Delhi Army Hospital, R&R, and she is currently practicing in Pune and Manipal hospitals and Sahyadri hospitals, Pune. So uh, we will start the session. Keyur, now you can present your slides. Over to you, Keyur. You are muted, Keyur. Just huh.
Uh,
Yeah.
Good morning, everybody. I'm Dr. Keyur Desai. I am a first year DNB resident at PD Hinduja Hospital in Mumbai. Uh, I hope my screen is visible to everybody and I'm audible. So I'll start with my case presentation. Uh,
Yes, start, Keyur.
yes, my case is of a 45-year lady, resident of Kalyan, a homemaker. The informant being the husband, who is reliable, and the patient was examined on 25th Jan 2026. She presented with chief complaints of swelling and rash around the eyes since 6 months, weakness in both lower limbs and upper limbs since 2 months, dysphagia since 1 month, and breathlessness since 1 week. The patient was apparently asymptomatic around 6 months back when she noticed swelling around both the eyes, which was insidious in onset, gradually progressive. It was associated with a reddish purple, non itchy, non photosensitive rash. There was no malar rash and no rash on the back of the neck or the chest. For this rash and swelling, the patient was initially being managed by a dermatologist. She was being treated uh, uh, for, I mean, she was receiving treatment considering it was an allergic condition, but she had no benefit with that. However, she had the rash and swelling had reduced with steroids, but it reappeared when the dose of steroid was tapered. Since 2 months, the patient also experienced weakness in both lower and upper limbs, which was insidious in onset, non-progressive. She had difficulty in getting up from sitting position and difficulty climbing stairs. She also had difficulty in performing activities involving overhead abduction like combing hair. But there was no difficulty in wearing footwear or buttoning clothes or holding objects. There was no diurnal variation of weakness, and the weakness was not associated with muscle pain. Since 1 week, the patient also has difficulty in lifting her neck from the pillow. Since around 1 month, patient complains of dysphagia, which is progressive, increased since the last 1 week. Initially, the patient had dysphagia only to solids. However, since the last 3 to 4 days, she has dysphagia to liquids as well, and it is associated with nasal regurgitation of feeds. Due to dysphagia, her appetite has considerably reduced and she's experiencing generalized weakness. Since 1 week, the patient is experiencing breathlessness at rest, which is progressively increasing. The patient has difficulty in speaking. She cannot complete the sentence. And it is also associated with cough with expectoration. On inquiry, the
Keyur, 2 minutes, Keyur. Do you have photographs of the rashes?
yes, ma'am, I'll come to that in the examination.
Okay.
So, on inquiry, the patient has a history of weight loss of around 8 kgs in the last 6 months. She has history of dryness in the eyes and mouth since 1 month, but there is no history of any parotid swelling. And like I mentioned earlier, she has difficulty in lifting her neck from the pillow since 1 week. There is no history of ptosis or diplopia, no history of facial asymmetry, drooling of saliva, no history of dysarthria, tongue deviation, no history of sensory loss or paresthesias in either the upper limb or lower limb. There's no history of fever, there's no history of Raynaud's phenomenon, no history of joint pain or swelling, no history of mouth or skin ulcers, no history of chest pain or edema feet. There is no history of any other drug intake apart from this steroids, and I'll come to the treatment history also. So, for this condition, the patient has also consulted a rheumatologist for which she was given uh, oral steroids and intravenous steroids on multiple days, with which her limb weakness has improved, but the dysphagia has persisted. She has also received one injection of rituximab around 2 weeks back.
So can we just, discuss regarding just the history part that you have, as of now covered a little
Yes, ma'am.
bit so that, later we don't miss the points that we need to add. So if
Yes,
you
ma'am.
can just go back, so to the weakness in lower limbs, right?
Yes, ma'am. Both upper limbs and lower.
Both upper and lower limbs. All right. So here, like you need to like give it in a little bit of story form, like how it started for the patient, and you need to describe, like like how it was initially, then how the patient noticed it, then whether how it is affecting the activities of daily living, whether like the severity of it, so whether she requires 1% support or 2% support to do all her activities. So all that gives us an idea about how severe it is.
Okay.
Okay, so
Okay.
that is one thing that I wanted to add. And Rash, you have mentioned, and the dysphagia also, like if you could just go there to the dysphagia
Yes,
slide.
ma'am.
Yeah, so even the dysphagia, you need to like tell like how it has changed her diet, like now is she only on liquid diet, and how it has like evolved, whether like this is since 1 month,
Yes, ma'am.
correct? So what have you written? Okay, progressive. So how it has been progressive. So a little bit, yeah, you can still tell all those things. And plus initial, like whether it is at the beginning of the deglutition. So in patient's words, like some things about, how the patient has mentioned it. So
Okay.
all that helps to differentiate the anatomical site of dysphagia. Whether it is at the initial part of deglutition, whether she requires water to, swallow the solids, or does she have that choking kind of sensation or sticking of the food. So all this helps to let us know whether it is the dysphagia according to the anatomical side. That is one thing. Second thing is, along with this, see, dysphagia, see, at the beginning of it you don't know whether this is dermatomyositis or whether this is an overlap. So dysphagia also occurs in another condition like systemic sclerosis overlap with the
Hmm.
myositis.
Yes.
So there, what all you have. So negative history, you can even tell a little bit, year itself, like what she doesn't have bloating, pain in abdomen. So after the food, there is no, like after she finishes her meal, there is no regurgitation. So that a little bit, if you could just, tell in your the current symptom description only, so that itself helps to differentiate.
Okay.
All right. Yeah. So symptom related negative history can be mentioned with the symptom, so that we know that you are trying to differentiate the cause of it. So even the muscle weakness, what you said, so whether it is muscular cause or whether it is neurological cause, so that negative history can be mentioned there. And the rest, CTD related negative history, can be mentioned at the end.
Okay, thank you.
Okay? Yeah. Yeah, go ahead.
Okay. So there is no significant past and family history. Personal history, her sleep is normal. Her appetite is markedly reduced due to the dysphagia. Her bowel movements are reduced and bladder movements are normal. Obstetric history, she has 2 pregnancies which were uneventful. There is no history of any pregnancy loss. And menstrual history, her periods have been irregular since the last 6 months and she's perimenopausal. So after the history, so this is a 45-year lady with periorbital swelling and redness in 6 months, proximal lower and upper limb weakness since 2 months, with neck weakness since around 1 week, progressive dysphagia since 1 month, and uh, uh, progressive breathlessness with cough and expectoration since 1 week. My first, I would like to consider the possibility of dermatomyositis first, and would also keep a differential as overlap with myositis.
Okay,
And I
Keyur,
would like
why
to,
overlap myositis?
ma'am, because she has complaints of dryness in eyes and mouth, and again, history of dysphagia since 1 month. So,
So would we see periorbital swelling in overlap myositis?
no, ma'am.
So
It's
that is the point against overlap myositis.
yes, ma'am.
So dysphagia can be seen in both the conditions. Okay, so let's go ahead, then we will discuss. Okay.
Just
So,
one second. So, any other differential that you want to give other than this? Like in family history, what did you ask for specifically when you have weakness?
I mean, if there is any history of similar history of any muscle disorder in the family, I mean, if there is any history of hereditary myopathies or something like that.
Okay. Anything else?
Um,
So, any history of malignancy. So, this
okay.
can even be paraneoplastic, right? Or
Yes.
cancer associated myositis, malignancy
Yes.
associated myositis. So, also she has Zika, you said,
Yes, ma'am. Zika symptoms.
correct? So, it can even be in malignancy, what it can also be lymphoma. Yeah,
Yes.
so you need to just keep the differentials. Maybe one more you can add. So malignancy associated
Malignancy,
myositis.
paraneoplastic myositis.
Yeah.
Okay.
So that is it. And one more thing, like in your breathlessness you mentioned earlier, right? Like she had shortness of
Yes,
breath.
ma'am.
So based on the breathlessness, so at the history level, you could differentiate whether it was cardiac origin or because of respiratory origin.
Ma'am, there was no history of any edema feet, and because there is breathlessness at rest, like difficult to elicit history of orthopnea or PND, but because there was no history of chest pain or edema feet, and so.
Keyur, what about ILD? How will you differentiate?
Ma'am, history of progressive dry cough and breathlessness, it will be a longer, slightly more subacute to chronic history of dry cough and breathlessness rather than an acute 1 week history.
Any specific rashes which you would see in these patients?
And mechanic hands is associated with
Okay.
anti-Jovan
Okay, and Raynaud's phenomena you'll
Raynaud's
look
syndrome.
for.
Mm.
Okay.
Yes.
Okay.
And just one thing is anything else, like it's a very short history, right? Of breathlessness.
Yes, ma'am.
So anything else that you will think of in this patient, in such patients, like she's received glucocorticoids, she's received all this. So what 2 things that you will think of? So she's
Ma'am, one is
immunosuppressed.
infections.
Yes. And another thing, she
And
has dysphagia, so aspiration.
aspiration.
Yeah, so these things also you need to just keep in mind, because in during your examination, so that will be important. Okay.
Okay.
Yeah.
One thing, Keyur, there are certain pneumonias, acute interstitial pneumonias, the ILDs, which can progress acutely also, like in those
Okay.
seen with OJ and EJ, those syndromes. But the points against those will be the skin rashes are not that remarkable in those syndromes. So even with the short history, we can get ILD in these patients. With acute failure,
Okay.
also they can
Yes,
present.
yes, yes.
Okay.
Okay.
Okay. Huh? So, ma'am, we can go ahead.
Yes, yes. Please go ahead.
Yeah.
So, examination, on general examination, the patient is conscious, cooperative, and oriented. She is visibly tachypneic. The patient is averagely built and nourished. Her height and weight could not be assessed because she is unable to stand. The patient is afebrile. Her pulse rate is 120 beats per minute, regular rhythm. Peripheral pulses are well felt. Her blood pressure is 110 by 70 millimeters of mercury, taken in the right brachial artery in the supine position. Uh, Respiratory rate is 28 breaths per minute, which is regular. She is using accessory muscles of respiration. Uh,
Okay. So, based on the vitals, what she has? So, she has
Ma'am,
tachycardia,
she has probably respiratory, she
tachypnea.
has tachycardia and tachypnea, so probably respiratory muscle weakness.
So, tachycardia by in such patients can be explained due to what all you think?
Ma'am, it could be either infections,
Mm,
aspiration, pneumonitis, myocarditis, uh,
mm,
I mean, acute, acute decompensated heart failure, and
mm. So,
uh,
first thing is because of increased muscular effort. So,
okay.
that itself can lead to, tachycardia. Then, cardiac involvement, PAH. Then, other things. Okay, you mentioned other things. Fine. Okay. All right, go ahead.
Uh, on examination, there is a periorbital violaceous rash consistent with heliotrope rash. She has uh, evidence of oropharyngeal candidiasis. Uh, there are papular erythematous lesions noted over both the MCP joints, consistent with Gotron papules. She also has
What
macular
Gotron papules?
papules. Yes.
Papules है क्या? इसमें इतना
Yes,
clear
and
नहीं.
actually, this is a photo like many days after her admission. When she was admitted, she had classical.
Okay,
This is the present day. I mean, just photo a few days
okay.
back. But when she was admitted, she had classical Gotron papules over.
Yeah, so Gotron papules and Gotron
Sign.
sign. How do you differentiate?
Some Gotron papules will be scaly erythematous papules over the knuckles and the PIP joints, whereas Gotron sign will be a macular erythema
Mm,
over other extensor surfaces like elbows and knees.
right.
How would you differentiate lupus rashes, lupus hand rashes from Gotron papules?
Ma'am, lupus rash, it is usually a non-itchy and a photosensitive rash, whereas the dermatomyositis rash is usually itchy and
Is there
uh,
something about the location of the rash which helps us to differentiate these two?
uh, yes, ma'am. The location of
So
the rash
the
or the extensor aspects of the knuckles and the PIPs is typical of dermatomyositis. Lupus rash.
see, so so it's
Mhm.
the interphalangeal area which is affected in lupus, whereas in case of
Okay.
Gotron papules, it is basically the MCP and the PIPs where the rashes are predominant. So
Yeah,
when the interphalangeal site is involved, that is likely a lupus rash, whereas when
Okay.
the knuckles are involved, that is likely a Gotron papule.
correct.
Okay.
Anything else like on face? How will you differentiate?
And face sparing of the nasolabial fold is seen in lupus rash,
Yes.
and in dermatomyositis it is usually the nasolabial fold is not spared if the face is involved,
Okay.
and also
Okay.
photosensitivity and presence of
Itching.
itching.
Itching, yeah. And what is inverse Gautrons?
Inverse Gauthron's rash is a acropapular rash on the palmar aspect of the hands.
Okay.
It's a hyperkeratotic papules on the which usually it's found in MDF5 positive dermatomyositis. And
What
Yeah.
is the characteristic sign of MDA5 dermatomyositis? What kind of rashes will you get over the hands?
inverse Gauthron papules will be seen, and along with that cutaneous
Yes,
ulcers.
yes, yes. It is basically the ulcerations. The Gotten
Ulcer.
papules will ulcerate over the hand. So that is the characteristic sign of
Okay.
MDA5.
Okay. And the lung involvement, what happens? Like usually, like what is the characteristic
It's
MDA5?
a rapidly progressive
Yes.
ILD,
So,
and
yeah. So if you see such rash, you have to be, like careful with respect to the monitoring of these patients. Yeah. Okay. So what is that? The last image you did not explain.
so this is periungual erythema, ma'am. She had
Okay. So it is because of what?
the dilation of the capillaries in the nail bed,
Yes.
and
That is seen in which all diseases?
that can be seen in lupus, systemic sclerosis, dermatomyositis, small vessel vasculitis.
So three diseases we commonly see: systemic sclerosis, we can see it MCTD, and dermatomyositis. So we have
Okay,
three differentials when we see periangual telangiectasis
telling
type lesions. Okay.
okay,
Okay.
And hair, like usually, like when you are telling about the examination, first thing you come from scalp. Especially
okay,
in females, you have to tell, like how are the hair and all, because lupus overlap is always common. So you have
okay, ma'am.
to start with the scalp and then come, lower down. So,
Did you do a nail fold capillaroscopy in this patient?
No, ma'am, it was not.
Okay.
Uh,
so what,
there
there was
is
no pallor.
no pallor, edema, icterus, cyanosis, clubbing, or lymphadenopathy.
Okay. Anything else? Like, what are the other sites that you'll be, like if you're thinking about dermatomyositis, so what all she doesn't have, like what you'll be looking for?
So, I will be looking for mechanics hands, calcinosis, any ulcers,
Hmm.
cutaneous or oral ulcers. Uh,
Ulcers, like very common over in dermatomyositis, oral ulcers.
no, ma'am, cutaneous ulcers,
Okay. Okay.
and looking for Raynaud's phenomenon, digital tip.
No, like what all other more, like other specific
Areas.
areas like shawl sign, V sign, all that you need to mention. Like in the sense when this question is asked,
Okay.
so you need to tell. So what all are the
Yes,
other
ma'am.
things that you'll see?
So
What, what about a rash on the thigh? What does that signify?
that is a holster sign which is seen in in on the anterolateral aspect of the thigh. So
Mhm.
seen in can be seen in dermatomyositis holster sign.
Does it has any association with paraneoplastic dermatomyositis?
I'm not aware about.
Okay, some literature say that it has some association. Sure. Let us move forward.
Okay. So I would like to examine the musculoskeletal system first. Uh, there is no asymmetry or muscle wasting noted. The uh, uh, at the bulk of the muscle in the upper limb, the circumference is 21.5 centimeters on the right side and 21 centimeters on the left side. And it is below the elbow, it is 17.5 centimeters on the right and 16.8 centimeters on the left side. Similarly, in the lower limb, the circumference is 38 centimeters on the right and 38 centimeters on the left. Uh, and below the knee, it is 27 centimeters on the right and 26 centimeters on the left side. The muscle tone is normal in all the 4 limbs.
Musculoskeletal examination you'll see for nutrition and tone and all. This all comes in CNS examination, right? So here, what all you're going to do?
Yes, ma'am. I'll come to the muscle power also.
Okay.
But
All right. All right.
yes. So muscle power was assessed by the MMT-8 scoring. For the neck flexors, the power is 3/10. For the proximal muscles, in the deltoid, it is 7/10 on the right and left side. Biceps is 8 out of 10 on the right and left side. In the gluteus maximus, it is 6 out of 10 on the right and left. Gluteus medius is 5 out of 10 on both the sides. Quadriceps is 4/10 on the right and left side. For the distal muscles, in the power is almost normal. It is 9/10 on the for the wrist extensors on the right and left side, and for the ankle dorsiflexors, it is again 9 out of 10 on both the sides. So the total MMT 150 score is 99 out of 150. Reflexes, the superficial reflexes are present. Plantar response is bilaterally flexor. Deep tendon reflexes in the upper limb. The biceps jerk reflex is 2+ on the right and left side. Rest of the reflexes are 1+ diminished. In the lower limb, the knee jerk reflex is 2+ on both the right and left side, while the ankle jerk is 1+ on both the sides. There is no evidence of any synovitis or damage in the joints. I would now like to also examine the cranial nerves. The first and second cranial nerves are normal. 3, 4, 6 cranial nerves, extraocular movements are normal. Facial nerve examination is normal. For the 9th and 10th cranial nerves, uvula and palate is symmetrical. Gave reflex is absent. The patient has a low volume and weak voice. The 11th cranial nerves, there is weakness of the trapezius and sternocleidomastoid muscles on both the sides. And 12th cranial nerve, there is no evidence of tongue deviation, tongue fasciculations or atrophy. To complete the neurological examination, sensory examination is normal in all the 4 limbs. There is no cerebellar or meningeal signs. The patient's gait could not be assessed, and single breath count could not be assessed because the patient is unable to I mean, just able to speak.
So still you can mention like whatever she's able to just mention that. So because that itself is like SBC is that only, no? Like how much she is able.
Yes.
So later on you'll be able to like after treatment you'll be able to compare like how much is she improving. So it is one of the things that you can note. It was initially what, even if it is 4, you can say it was that difficult for her. Okay.
Okay. So,
Because she is able
yes, it
to
was.
phonate, na? Like it's not like it is weak, but she is able to phonate, right?
Yes, I'm just like barely able to talk, and so maybe yeah, it's 3 to 4 only.
Yeah, so you need to have, so you can keep the record, like after treatment, how much it has improved.
Okay.
Yes. What does it tell you, SBC?
And the respiratory muscle weakness and the need to intubate the patient electively and
Basically the function, respiratory muscle function.
sorry.
Respiratory muscle function, like how weak it is, like, how involved it is,
Yes, ma'am, the respiratory muscle
diaphragmatic weakness,
diaphragmatic.
how severe it is. Yeah.
Keyur, you said distal muscles were not weak. In the power, you said the distal muscle examination was normal, the proximal were
Yes,
weak.
ma'am.
If you had
Yes,
got a distal muscle weakness along with proximal, what would have changed
yes.
in the diagnosis?
Then you would suspect something like inclusion body myositis, which has both proximal and distal muscle involvement.
Yes, and some of
Uh,
the hereditary myopathies also have
myopathy.
distal and proximal muscle weakness. Yes, that is it.
Yes.
So, like inclusion body myositis. So, what do you think? Like, like it is common in whom?
Sorry, ma'am, I didn't get your question.
In inclusion body myositis.
Yes, ma'am.
Yeah, so it is what predominant? Male, female? Yeah.
It's usually male
Yes,
predominant.
yes. Yeah, it can occur even in females, but yes. And the history, how is the history usually?
Usually occurs at an age of more than 50 to 60 years, and it may be usually asymmetrical involvement,
Mm-hmm.
and the affects the wrist and finger flexors and the uh, the quadriceps muscles.
Mm-hmm.
Uh, they're the most commonly
So it is slow, yeah. So even that, it is very slow evolving, and you'll have more of wasting, like wasting
yes,
that will be seen. Yeah. So
And the
good
response
to
to
know about
steroid
it.
is very weak in
very weak.
inclusion body mass.
Yes.
Okay,
Okay.
next, Keyur.
Yes. Uh, So, in the other systems, uh, the respiratory system, her respiratory rate is 28 per minute regular with use of accessory muscles. Trachea is central. Chest is bilaterally symmetrical with transverse diameter more than anteroposterior diameter. Chest expansion is around 2.5 centimeters and it is uniform. On auscultations, bilateral basal inspiratory crackles can be heard. Uh, Other systems,
Wait, wait, wait,
cardiovascular system.
wait. So auscultation bilateral. So what are the sides? Like where you are able to hear it?
I mean the basal, so like infra
So where,
scapular.
like, so you have to mention where it is infrascapular, interscapular, whether it is infra axillary. So you have to mention the sites, and also
Okay.
how, like, what is the characteristic this thing, like whether they are fine or coarse. So because why? So you're what you expect. If it is ILD, what you expect?
With ILD, we expect fine and inspiratory Velcro
Yes.
crepes in
So
the.
that's what. So your history is quite short, right? So later it will help you with the DDs. Like they can ask you, okay, it is 1 week history. So you
Yes,
can say
yes,
that they were fine. So they were not coarse. So coarse will be more, in favor of aspiration and infective also. They can be more
yes,
coarse, and it is not usually bilateral. So all those things, like they'll help you further down when you are going to defend your diagnosis.
yes,
Okay, so that time. So you need to mention in a systematic way, like where it was, what was the site, then what was the characteristic of that crackles and all those things. You need to just mention it in a proper way. Okay. Yeah, yeah. You can.
cardiovascular examination, S1, S2 was normal. There was no murmur. For
Mhm.
abdominal examination, abdomen is soft and non-tender. Uh, So, at the end of my history and examination, I would summarize my case. This is a 45-year lady with subacute onset of symmetrical proximal upper limb and lower limb weakness with.
वहाँ पे एक बार भाजीराव उन्हें चटनी करपत बुलाते थे बरोबर
Hello.
Yes,
Yeah.
yeah. So, this is a 45-year lady with subacute symmetrical proximal upper and lower limb weakness with bulbar involvement and respiratory muscle weakness with the typical skin features. Uh,
What are the
my most
like,
probable
typical?
diagnosis,
Okay, but you say with skin rash, suggestive of what? What typical skin features?
okay, okay, ma'am,
Yeah.
Or
skin
you could have
with,
mentioned heliotrope rash also.
Yeah. Yeah.
okay.
And also, you said organ system involvement. You have not written here. You're thinking of respiratory system, right?
Um, Yes, ma'am.
Involving what organ system? So on examination and history, so involving the जो है ना उसको
Yes, ma'am.
dyspnea है plus
Involving the respiratory muscle weakness with Gotran's papule sign and heliotrope rash and most probable diagnosis of dermatitis. I would like to rule out an underlying ILD on further investigation.
okay. Yeah, so you need to again, you cannot just say one diagnosis, no, like at the end of it. So this is your first diagnosis. You're thinking of dermatomyositis based on all these features.
Yes.
Yeah, so you've completely ruled out overlap. And you did not mention anything about Sikka thing, like did you do Shermer's? So you need to do that. Shermer हम क्या बस ट्रिप लेके जाएंगे, Shermer करेंगे. Then oral, other than like if she has Sikka, which you mentioned, so oral dryness, salivary pooling, ये सब. So you had that, no? Initially, in your
Yes, there
history, you had
was
Sikka,
dry.
but in
Yes.
examination part, there was not like nothing mentioned about Sikka, and now there is again no Sikka. So whether she has, she doesn't have, at the end of your clinical examination. Yeah, so you need to do that, okay? So you cannot like पहले जो हमने एक symptom रखा है, then it suddenly doesn't, like you have to follow it through in your examination also.
Okay, ma'am. Sure.
Yeah. Yeah, so because that is one thing that goes in favor of, as you said, overlap, or it can be secondary Sjogren syndrome, no?
Okay.
Yeah, so that also can come in your diagnosis. Then okay, so based on that, so whatever initial differentials you have kept as your provisional,
Yes, ma'am.
so those have to be, so based on those, okay, so what were the features going pro and against it? So those things have to be, like those are the things that you'll be asked basically. So initially you thought of this.
Okay.
So what are the clinical on examination? What are the things that did not go in favor of those? Hmm?
Okay.
Yeah.
Keyur, what are the causes of Zika other than connective tissue disease? If you think she's not having overlap connective tissue disease, then why is she having dryness of eyes and mouth?
It can occur due to conditions like hepatitis B, C, any radiation exposure of the head and neck, any radiation exposure of the head and neck.
Mm-hmm.
And
Was she on any medicines, antidepressant, anxiety medicine?
no, ma'am, she was
She
not
was
on
not on any
any
medicine.
other. She has no comorbidities and not on any other treatment.
No diabetic.
No, not that.
And parotid gland examination, if you're saying Sikka, maybe likhna hai.
So I forgot to mention that.
Yeah.
Parotid glands were not part of it.
Okay. All right. Okay. So that you need to mention. And anything else, ma'am?
All good. The treatment part you are covering? No.
Yes, ma'am. I'll be covering the treatment
No,
part.
treatment, what you've given is okay. The initial part, like I just forgot, like जो आपने treatment mention किया है ना. So in that also,
yes.
like how has she responded? Like how much, you said partial improvement. What was the partial improvement that occurred? Like how much? So that is why you initial जो history रहता है, it has to be a little bit in detail so that after treatment, what were the things that improved? Okay, so history I'm talking
yes,
about,
so
the
the
initial
history,
thing.
initial treatment history, she had received oral and
Yes,
intravenous steroids,
yes,
and after the
correct. That I
steroids,
got it.
her periorbital rash swelling had improved, and even her
Okay.
muscle weakness had
Yes,
her limb
correct.
muscle
So you're
weakness had
saying
improved, but
the muscle weakness has improved. So what she was
improved.
able, so that's what everything has to be in a. So you're asking history, right? You'll not be asking her after muscle power improve hua ke yes or no. It is not a yes and no.
Correct.
So it'll be like she'll tell you. So after treatment, she was able to do this, what she wasn't able to do earlier. So you always have to mention in terms of activities of daily living. So what were they initially and how they improved after the treatment part. Okay, so in history part, just
Okay.
remember, like it's okay. You can always go back and this thing, but make a note of it. Like when you're giving history,
Okay.
no, it always has to be in activities of daily living format, and then after treatment, how did it improve in the same format? Okay.
Okay. Sure.
Yeah.
Based on history and examination, which antibody are you suspecting, Keyur, in this patient?
So, ma'am, based on history examination, because she has typical skin features, then we can expect MI2 antibody, but the dysphagia and the respiratory muscle weakness is a little goes against this. So, uh,
Doesn't go exactly against it. You can
Still,
have
she
to.
can have. With MI2, she can still have.
The only thing is refractory
and
thing.
TIF1 gamma
So
antibodies are again a
wait,
high
wait.
Sorry.
You're saying me too, right?
Yes, ma'am, me too.
So how is the prognosis?
Prognosis is usually good. It responds well to
Yeah.
steroids, and
Yeah. So she did not.
yes, ma'am, the dysphagia and the respiratory muscle weakness is
Yeah. So we don't know like she has received even IV, right? IV steroids. You
IV
mentioned.
steroids also she has received. Yes,
Yeah. So the rituximab also she has received.
this
That.
to
That was
also
this
one.
thing. Yeah, and also like okay, to say that she's received in your history itself, to say she's received rituximab, she's received like all those things. So it's very few patients, attenders, and all can give you exactly. So initial this thing you have to mention what is the education status of the informant. Okay. Otherwise, many people may not be able to tell you. They'll just say injections mile hain inko. So that time you'll be telling how frequent, and also based on that may suggest of rituximab. So that is how you need to, tell the history. Okay. So initially, if you say,
Okay.
okay, the patient's education status is all that, so okay, then you can rely on, like what the history was given. But in many cases, it is not so. So that time you have to tell, like, okay, so these were the medicines, so this was the duration, like how she was receiving, so may suggest of this. Then injections, okay, so this was the frequency, and it was hospitally administered and all that, so may suggest of it. So are you getting my point?
Yes, ma'am.
Yeah, so that
Sorry
is
to
how.
interrupt. We have 7 to 8 minutes more to finish the
All
case.
right, go ahead.
Um,
Yeah, go ahead. So have you
so
written? Okay, fine.
sorry, ma'am, what were you saying?
No. Chalo. I thought you were just going to mention the what all was done. Okay, batao.
So these are the chart of the routine labs of the patient. So she had come to us on 25th Jan earlier this year, and uh, her labs were significant for thrombocytopenia. Platelet was 93,000. ESR, CRP were elevated. CRP was significantly elevated. Her SGOT, PT were raised. CPK and LDH they were 538 and 634 respectively. Uh, and uh, I mean, vitamin D3 was normal. TSH was borderline. Ferritin also was elevated. Uh, so these were her routine labs, and she also had a KL6 done. So around 1 month back, it was 3,340, and this is we had repeated the KL6 during her current admission, which had come down from that value. Uh, and during admission, I mean, during hospitalization, she also had a significant drop in her HB. So we had worked her up for that. Her DCT was 3 plus, her retic count was progressively rising. So, this anemia did not respond to pulse steroids. So I'll come back, I'll talk about that also in the treatment part. Her specific investigation, so myositis profile had shown an MDF5 antibody was strongly positive, Rho52 antibody was strongly positive, MI2B was borderline, and SRP was borderline. A PET CT scan had, I mean, apart from the increased muscle uptake, there was no other hypermetabolic lesion resembling a primary site.
So
And
that is what, so
a CT.
myositis profile MDA5, no? So if you see the elbow lesion, so there was a small this thing, so maybe that may ulcerate in the future. There was a small
Yes.
lesion kind of it, which was, not exactly just generalized erythematous. It was a lesion. Yeah. Okay.
Okay.
Fine.
Then her PET CT, yes, and the HRCT thorax was done, which had showed a left lower lobe collapse consolidation, and along with many scattered uh, uh, opacities, so which was most likely infection, and also mild interstitial thickening, which you can see on the right lung lobe in the figure. So mild interstitial lower lobe predominant uh, peripheral thickening, which probably was suggestive of an underlying ILD. And she also had a skin biopsy done. This was prior to admission by the dermatologist. It was just showing interface dermatitis.
So you can differentiate based on skin biopsy, lupus and dermatomyositis.
Yes, I'm not aware about
Yeah,
the
you cannot.
differentiating
It is
feature.
going to
Cannot,
be,
we
you
cannot.
cannot.
The
So it is
only
like,
point on the examination which differentiates is the excessive itching, which is seen in dermatomyositis as
Okay.
compared to the lupus rashes, and the location of the rashes, which help to differentiate the two. Biopsy will not help in differentiating the two.
Okay.
Mhm.
okay, go ahead, go ahead.
So after in the history examination and the lab reports, I'd like to make a final diagnosis of this is an MDA5 positive dermatomyositis with a likely lung involvement in the form of mild interstitial lung disease. We haven't actually done Sherman's test in this patient.
That you can do bedside. You don't need to
Yes,
do it.
ma'am. But
So, what is mild ILD? You'll say early ILD, no?
early IIT, sir.
Yes, mild, moderate, severe. You cannot. PFT, she's unable to perform. Right?
And we cannot do because she has
Yeah.
breathlessness at rest.
All right. All right.
So, this patient we had uh,
So usually, do you expect so many antibodies like coming positive?
uh, so ma'am, actually it's I mean one or two antibodies are usually strongly positive and the
Mm-hmm.
other
And MDA5, है ना?
MDA5 strongly positive. Yes, ma'am.
Correct. So on IF, what do you think the pattern would look like? IFA, ANA. Staining पे कैसे दिखेगा? MDA5.
Cytoplasmic, speckled, or what pattern you'll see on AN?
Cytoplasmic speckle.
Yeah, so it'll look cytoplasmic, no? Predominantly cytoplasmic.
Do we commonly see MDA5 and Rho52 together?
No, ma'am, it's not seen together
One
usually.
is myositis specific antibody and one is myositis
One
associated.
is
So
a
they are not commonly they are not seen together.
associated. Yes, ma'am.
So this is not
Not
something
commonly
which is
seen.
very, very common.
Yes, ma'am.
And malignancy screening.
Yes, ma'am. We had done a PET CT scan. There was no uptake in any particular organ to suggest any primary lesion. And
So how do you decide on malignancy screening? Like what all you'll do? Is there something that can help you? Are there any not exactly guidelines, but do you have anything that has come up, that can help you screen malignancy in myositis patient? So there is
Any
IMAX
and
initiative, yes. So in that, based on the
If you're
risk,
waiting for a delayed package, you can check its status at
yeah.
the
So
order
based on the
port on Amazon.
risk, what are the clinical manifestations, the antibodies present? Okay, so based on that, you have a stratification as
okay.
low risk, intermediate risk, and high risk. So based on that, you have basic panel and higher panel that is available.
We
So
have
the
2 minutes
screening you can
more.
do. Yeah, screening can be done accordingly. Okay, fine. Okay, so treatment.
So treatment, this patient was admitted to Hinduja Hospital, and we had decided to electively intubate and mechanically ventilate her. Because of the dysphagia, we had inserted a Ryle's tube in her. And she was given intravenous immunoglobulin at a dose of 2 gram per kg over 5 days. after the course of IVIG, she had a gradual, at least partial improvement in the dysphagia and neck weakness, uh, and uh, also she's currently she's has been weaned off the ventilator. She's tracheostomy and she's maintaining saturation on TPs.
So do you want to give
She
IVIG further?
sorry, ma'am.
You want to give IVIG further? Like for how? Like you want to again, give her IVIG, or is it sufficient once?
Actually, ma'am, I'm not aware about the guidelines, like whether, I mean, how frequently can IVIG be repeated
So
once?
she has a good response, right?
Yes,
So
ma'am,
when
she
they
has
have a good
had
response, we
uh,
usually give
at,
IVIG again. So at least for a year's time, till the patient recovers, especially in severe myositis. So she has organ system involvement, she has pharyngeal involvement. So based on that, you give. Huh? ठीक.
okay.
Anything else?
And
Anything
yes,
else, like you've given rituximab, fine. So rituximab.
yes. So we also during the admission, I mean, this was just a few days back. We had given antibiotics for the infection, and she had received 1 dose of rituximab. We also gave her the
So you
second
read
injection.
about RP-ILD. So when you say it is RPI, so now as there's no time, so you read about
Okay.
RP-ILD. When do you call it RP-ILD? In RP-ILD, again, the treatment varies. All right, so there
Okay.
is more of, nowadays we use combination therapy. So read
Yes,
about
triple
that.
therapy. Yes.
Yeah, so read about that, and then how you'll be further evaluating, like in a sense, how you'll be following up the patient, how frequent you're going to do
Yes, ma'am.
the imaging. So just read about. So these are the questions I'm just mentioning to you, so you can read
Okay.
about all that. All right, and anything else, ma'am? Like,
No, it's fine. I think time is almost over,
yeah,
so it's fine. Yeah.
Thank you,
okay.
dear moderators. So we'll move on to next topic of guest lecture.
Thank you so much for calling us.
Thank you.
Thank you.
Yeah, Keyur, so you did well. Yeah, just thoda sa fine tuning,
Sure.
make you much better. Yeah, all right.
Okay. Thank you, ma'am.
Okay, practice. Yeah, bye. And best of luck.
Thank you.
So are we done? Dr. Digvijay?
Today we have our guest speaker, Dr. Prasanna Kumar. He is DM from KGMU Lucknow, and he is now practicing at Vizag, KIMS Icon, and he has his own clinic. He has several publications in the field of scleroderma, Sjogren's disease, sarcoidosis, and we have seen managing him complicated cases of IgG4 and Erdheim-Chester disease. So over to you, Dr. Prasanna. You can share your screen now.
Thank you, Dr. Digvijay. Am I audible?
Yeah, you are audible. You can share your slides.
Yeah, sure.
Yeah.
Is my screen visible?
Yeah.
Yeah, thank you. Thank you for giving me that.
Dr. Prasanna, you have 35 minutes to complete your lecture. Then we'll have 5 to 10 minutes for question answer.
Yeah, sure.
Yeah.
Thank you for giving me that type of Bahubali type of introduction about me. So I'll start my lecture with two cases. followed by the natural history, how IgG4 takes its role in a patient's life. So starting with the first case, 67 years old. 1 minute. No, 67 years old male presented to us with history of chief complaints with swelling on the right upper eyelid for the last 8 months and 2 swellings in the bilateral submandibular areas for the last 2 months. So illness started with when the patient noticed a small nodular painless swelling of 1 centimeter on the lateral aspect of the right upper eyelid and away from the eyelid margin. So this is the, am I audible, right?
Yes, you are audible.
Yeah. So this is the swelling on the right upper eyelid. We can see on the right upper eyelid margin and 2 small swellings in the submandibular area. So size of the swelling progressively increased, causing the narrowing of the lateral palpebral fissure. And after this eyelid swelling, 6 months later, he noticed 2 small, painless oval swellings in the submandibular area, which were equidistant from the midline. So at this point of time, we had a lot of differentials like Sjogren syndrome, sarcoidosis, DILS. So according to that, we had asked the negative history. However, there was no history or suggestive of any type of CTD. So coming to the general examination, he was moderately built. It was also almost all, everything was normal except the local examination. That is, local examination showed swelling of the eyelid of around 2 into 2 centimeters located on the lateral aspect of the right upper eyelid and 2 symmetrically placed swellings equidistant from the midline in the submandibular area. So when we had done this bidistal palpation test, we were able to confirm that they were submandibular glands. So workup revealed hemogram was completely normal. ESR was only mildly elevated. Other than that, rest of the workup was completely fine. So urine routine was normal. TFT was normal. Here, when we had kept the differentials, according to the when we worked up, ANCA was negative and IgG4 levels were very high at the level of greater than 3.56. So when we went ahead with the local imaging. That is when we had done the MRI. MRI showed ill-defined, heterogeneously enhancing soft tissue attenuated lesion of 2.9 into 2.1 into 2.8 centimeters involving the extraconal compartment of supralateral quadrant of the right orbit. And here you can see the base. So we had taken the histopathology from this area. So histopathology showed sheets of foam cells and histiocytes with numerous Toton type of giant cell. This is one Toton type of giant cell with numerous nuclei in that. And along with that, there are number of plasma cells which were highlighted by CD138 positivity and IgG4 positive cells were greater than 10 per high power field and CD68 positive histiocytes seen in the background. So when we got this biopsy report, we were actually confused to see that we are dealing with a lesion or soft tissue lesion which is actually had biopsy showing two diseases. One is IgG4 with positive findings in the biopsy showing lymphoplasmacytic infiltrate with IgG4 positives greater than 10 per high per field and this ratio greater than 40%. So we are sure this biopsy nearly shows that it is IgG4. But what about the rest of the findings like for sheets of foam cells, histiocytes, multinucleated Toton type of giant cells? So we went ahead with the PET CT to look at the systemic involvement. What are the other systems involved? So here we can see the lacrimal gland area involved, and we can see bilateral submandibular gland, hyper FDG AVDT, and we can see the FDG AVDT in the bilateral lower lobes of the lung in the form of GGOs, and in the infra-abdominal part of the aorta. Aorta also this is called as peri-aortitis. The other areas actually did not show the image here. The other areas which have shown FDG FDT were seminal vesicles and mesorectum and tail of the pancreas. So now we had seen the multisystemic involvement. So now how do we proceed? So when we had seen this, we started reading the differences between how this IgG4 as well as Adam-Gested disease differ. So IgG4 is basically a multi-system autoimmune disorder, whereas ECD, that is Adam-Gested disease, non-Langerhans cells, histocytic disorder. The most important differentiating points are bony involvement is rare except in one condition in IgG4, but in the case of Adam-Gested disease, greater than 95% of the patients will have bony involvement in the form of symmetrical bony sclerotic lesions. When it comes to skin involvement, in the case of IgG4, it is very rare. Otherwise, it presents as a small cutaneous pseudolymphomas. In the case of ECD, this yellow periorbital xanthelasma on the both upper eyelids is very, very commonly seen. And when we look at the abdominal aorta involvement, here in our case, we have seen the infrarenal part of the abdominal aorta being involved. That is actually commonly seen in IgG4 when compared to ECD, where we see more of thoracic involvement. And the other important difference is like CTKB showing multiple wedge round-shaped lesions in the, not in our case, in general in IgG4. This is one of the important difference. In ECD, that is, we see usually hairy kidney. So, in view of high uptake on PET in large vessels, result of inflammation, he was planned for immunosuppression with 1 mg per kg, followed by rituximab. And we had stained the mutation. In Erdheim-Chester disease, we have a mutation called as BRAF V600E mutation. It was actually negative by immunohistochemistry. This we have done just to rule out, not rule out, because in around 50% of the cases, BRAF can be negative, even in ECD. However, the clinical picture, the histopathology, and the way the patient presented really made us to go towards IgG4 rather than Erdheim-Chester disease. So he was given rituximab. So at the end of 6 months, he was planned for repeat PET-CT. So repeat PET-CT showed significant resolution of inflammation. This is the repeat PET-CT. We can see the clinical improvement of the right upper eyelid swelling along with the significant resolution, complete resolution of the right orbit, even in the lungs, even in the mesorectum, even in the aorta. So the final diagnosis IgG4 related is involving the various organs of the body. So he was receiving maintenance dose of rituximab every 6 months, and later, as usual, our patients do this, they are lost to follow up. So this case was published before after this improvement in the IGR. So current admission, basically he presented with history of jaundice for the last 1.5 months. He was lost to follow. He received around 3 maintenance doses of rituximab. He was completely fine. He was off steroids. So he lost to follow due to his son's marriage. So current admission, he presented history of jaundice, pruritus, clay-colored stool, and mild periumbilical spasmodic pain. So based upon this clinical history, we were actually sure that his biliary tract or pancreas might be involved. So the investigations revealed high direct hyperbilirubinemia along with very high ALP levels. However, amylase and lipase were normal. When we went ahead with the MRCP showed, I think everyone is able to see this stricture. This is a long segment stricture, which is actually in IgG4 is a very classical thing, where we see the stricture of the common bile duct at the lower end, not at the IHBRD level, at the lower end. This is one of the important feature of IgG4 related cholangitis. So the PET scan revealed right infraorbital area, again involvement of all the organs. So now it has actually involved the bulky pancreas with IHBRD also, along with the left renal artery has also been involved, the new gland. So we are dealing with relapse of the IgG4 related disease. So the thing is that he was actually planned for intervention for the ductal dilatation. Due to that ductal dilatation, he actually lost his life due to heavy bleeding as well as multi-organ dysfunction syndrome. So case 2, this was also published from KGMU only by Dr. Parag. So case 2 actually shows 39 years old male who presented with history of bladder urgency, frequency, and dysuria. So on evaluation, actually I have cut short the case because of time premises. So he presented with history of lower abdominal pain. On evaluation, the CT showed a pedunculated mass on the anterior wall of the bladder. And on further evaluation, it also showed a perigastric mass along with the nodules around the gastrum. So when this biopsy was taken from this perigastric area, it showed classical picture suggestive of IgG4. However, in this also, two important features of IgG4 biopsy were missing. There is storiform fibrosis as well as obliterative phlebitis were missing. Other than that, the rest of the histopathology and the clinical picture is suggestive of IgG4. He was started at 0.6 milligram per kg prednisolone and rituximab. Now he's doing well. He is off steroids and maintenance rituximab is going on. So this is how IgG4 behaves. One actually presented in a localized way, one actually presented in a systemic way. So coming to the IgG4 disease in general, there is a famous metaphor for IgG4. Here we can see a small dot. Actually, this is how IgG4 behaves, like a small dot is going and hiding in the darkness. We don't know what is going on. We'll be able to see the visible swellings on the lacrimal gland. When the light has been thrown to the research, it has been found that a crow flying in a dark night has been revealed. That is a single crow, which is actually presenting in various different forms involving different organs. So this is a small, just to make this presentation light. You can see this, I think everyone has seen a movie called as Aparachit. In this Aparachit movie, we have three important characters. This guy is very innocent and he's a lawyer. And second guy is a lover boy. And third one is the guy who punishes all the culprits. So at the end of the movie, or at the 45 to 50 minutes after the movie, we'll come to know that he is that single guy. So this is the way we have to understand IgG4. It's don't go deep into this. This is just for to make this presentation light. So coming to the history of IgG4, history of IgG4 dates back to 1892 when John Mikulicz actually described a disease with symmetrical lacrimal and salivary gland enlargement. After this, in 1961, Sals described a pancreatic disease called as chronic inflammation and cirrhosis of the pancreas. After this, in 1990, concept of autoimmune pancreatitis was brought into light, and in 1995, Yoshido et al. Has actually proposed a term called as chronic autoimmune pancreatitis. All these three are gastroenterologists because usually patients will have this aggressive type of pancreatitis, aggressive type of cholangitic involvement. So mostly this disease used to be recognized or used to be treated by the gastroenterologist in the initial stages. And in 2001, Hamano et al. Has actually have seen that high levels of serum IgG4 in autoimmune pancreatitis. And in 2004, Kamisawa has proposed a term called as IgG4 related autoimmune disease. So, however, we have seen the same disease going on with different specialities, going on different like in gastro, patho, medicine, or ophthalmology. So, in 2011, our hero John Stone has actually recognized this and actually has called the meeting symposium, international symposium, where he labeled that IgG4 is a simple single systemic disease with various presentation. This is the international symposium where IgG4 related disease has been recognized, and from then on, the guidelines have started coming as a systemic disease as a single type of guidelines. So these are nearly around 150 delegates attended that first meeting. He is John Stone. So coming to this is the various IgG4, how IgG4 used to be called before. It used to be called when it involves the autoimmune hypophysitis, Mikulicz disease, Cutner's tumor. Now we know that it is a single disease. So coming to the spectrum of IgG4 related disease, basically it can involve any organ of the body, from the pituitary gland to the lymph nodes or anywhere in the body, and it even involves the prostate gland, as we have seen in our case, seminal vesicles getting involved in one of the case. So, based upon this, they have divided the IgG4 into 4 clinical subtypes. One is pancreato-hepatobiliary disease, retroperitoneum and aorta, head and neck limited disease, and Mikulicz and systemic disease. In this, the points to remember is basically the age of presentation almost same in all the things, and male predominance is actually is not seen in head and neck limited disease. Other than that, the rest of the clinical subtypes where male shows the high predominance. And here we can see serum IgG4 concentration is actually normal or mildly elevated in the retroperitoneal fibrosis. It does so. It shows that even with the case of even in a case of with normal IgG4, but with the clinical high suspicion of IgG4 related disease, we should go forward with the evaluation. So coming to the pathogenesis, here we can see the naive B cell when it gets activated by the autoantigen. Autoantigens which were identified, however, it is not confirmed but identified, were alpha carbonic anhydrous of Helicobacter pylori, which resemblance to humans alpha carbonic anhydrous, and plasminogen binding protein of Helicobacter pylori, and ubiquitin ligase of pancreatic cancer of humans. Actually, they have molecular mimicry when they activate when the B cells are activated. And after activation, when they get into interaction with the two, these are the two important cells in the pathogenesis which have been identified. So one type of cell is CD4 cytotoxic. This is CD4 cytotoxic T cell. In this is a special type of CD4 T cell where it has the SLAM F7 marker on its cell membrane. And when it gets activated, when these two interact, it leads to release of this fibrogenic cytokines in the form of IL-1 beta and TGF beta, and at the same time granzymes and peripherins which actually damage the tissue. And here, if in this case, this is type 2 T follicular helper cell, it can release in the form of interaction release IL-4, which actually is responsible for the class switching with immunoglobulin level, that is IgE and IG4. This is the reason why in IgG4 we see more number of IgE with allergic response, at the same time higher number of IgG4 levels. So genetically they have seen HLA-DR-B1. So when we have, this is the current immunologic model, antigen presentation. So this is the antigen presentation, differentiation into CD4 as well as T follicular hyper T cells. After that, they move into the site of inflammation where they produce all these fibrogenic cytokines, causing the fibrosis of the involved organs. At the same time, releasing this class switching in the form of IG4 and IgE. So we have seen that high levels of IgG4 are seen. So we don't know whether the IgG4 are still pathogenic or not. This is because when we see the unique properties of IgG4, here if you see, this is the heavy chain. Immunoglobulin has 2 heavy chains and 2 light chains. The problem in not the problem, the actually basic structure of IgG4 is that the usual amino acid sequence which is found in the CH2 domain of immunoglobulin of IgG1 is actually replaced by CPSC, cysteine, proline, serine, and cysteine. So due to this, what happens is the interchain disulfide bonds get weak and the interchain gets strong. So when we see this is the if this is the IgG4, there is a dissociation leading to what is called as FAB arm exchange, leading to what is called as a weak negligible binding of complements. And so when there is negligible binding of the complements or immunoglobulin, there will be complement pathway does not get activated and results in the poor immune activation. So this is why even now the role of IgG4 is still questioned whether it is anti-inflammatory or it's a byproduct of the whether it's pathogenic or a byproduct of the excessive inflammatory stimuli. Coming to the clinical manifestations individually, I'll not go through all the manifestations. I'll just tell you the important things. So clinical manifestation basically is a male predominant disease. Multiple organs can be involved at a single stage, that synchronously or metachronously. So due to the long latency period of the presentation, the clinical detection and 60% of the patients have some degree of irreversible organ damage at the time of presentation, like in the case of retroperitoneal fibrosis. When we come to the eyes and orbit, we can see in the form of dacroadenitis, proptosis, scleritis, and nasolacrimal duct obstruction. This is the lacrimal gland enlargement. When the orbital region is involved, it presents in the form of ocular myositis, perineuritis of the optic nerve, and trigeminal nerves in the form of, it can present in the form of orbital inflammatory pseudotumor, which has lot of differential diagnosis. And one of the specific feature which has been radiologically has been seen in many of the IgG4 cases is infraorbital nerve enlargement. This is one of the specific to IgG4. Coming to the differential diagnosis, we have various lymphomas can present in the same way, Graves' orbitopathy, GPA, and sarcoidosis. However, the histopathology as well as the clinical presentation should help us in differentiating from these conditions. Coming to the salivary glands, the major and minor salivary glands can be affected by IgG4-related disease. And one of the common disease previously, which was known as Miklush disease, is a part of IgG4-related disease, where there is enlargement of bilateral parotid and submandibular glands along with dacroadenitis. So the differential diagnosis at this stage would be Sjogren's along with sarcoidosis, and however, the lymphoma can also be seen. So when we look at the differentials, this is the differential diagnosis between Sjogren's syndrome and IgG4 because both of them can present with Zika symptoms. How do we differentiate them clinically and after treatment? So if we see Sjogren's syndrome, the parotid glands are actually predominantly involved, but in the case of IgG4 related disease, submandibular glands are predominantly involved. Not that parotid can't be involved, but submandibular is predominantly involved. This is painful presentation because I think everyone knows that how a Sjogren's syndrome patient presents with acute parotitis most of the times, but it is painless presentation. And antibody positivity is seen in Sjogren's. And at the same time, this is one of the point which I have found. Xerostomia it most of the time will not improve with steroids in the case of Sjogren's syndrome. That is because we know that Zika symptoms in Sjogren's syndrome are almost always at the end stage, requiring a replacement pilocarpine most of the times in the case of Sjogren's syndrome. But it is not the case of IgG4 related disease because the Zika symptoms of IgG4 related disease might improve with steroids. Next, coming to the IgG4 related lymph nodes. IgG4 related lymph node, we can see concomitant lymphadenopathy. What does this mean? Lymphadenopathy, concomitant isolated lymphadenopathy can also be seen, but most commonly we can see concomitant lymphadenopathy, that is with involvement of other organs. So generalized lymphadenopathy along with polyclonal hypergammaglobulinemia, that is IgG and Ig elevation are seen in the case of lymph nodal involvement. So biopsy is very problematic to interpret from the lymph nodes because non-specific things like IgG4 lymph node is most of the times positive for IgG4 plasma cells. At the same time, hypergammaglobulinemia is frequently seen. If we see the differential diagnosis, one of the important slides for the residents. So if we see the differential diagnosis of this lymphadenopathy, here if you see, these are the mimickers of the IgG4 related disease. These are the areas of overlap. That is, this mimic and IgG4, what are the common areas? Why do we get confused? And these are the features which differentiate them. Suppose if we take this multicentric Castleman's disease, we know that it also has extensive lymphadenopathy. High IgG4 also seen. IgG4 positive plasma cells are seen. So till now, everything is common. What is the most differentiating thing in this? The MCD is actually high hyper IL-6 syndrome. B symptoms are not seen in IgG4. If B symptoms are present, always suspect that it is up to IgG4. Next is high CRP. And if you see this Rosai-Dorfman disease, in which patient presents with massive lymphadenopathy, it is very, very uncommon in the case of IgG4 related disease. Otherwise, and the other thing, biopsy, that is S100 and CD68 positivity is seen in the case of Rosai-Dorfman disease. And again, if we take this malignant lymphoma, the B symptoms are rarely seen, and bone involvement. Bone involvement is rare in the case of IgG4 related disease, except in one condition which is called as angiocentric eosinophilic fibrosis. And hypercalcium is also rare in the case of IgG4. Similarly, the other DDs. Coming to the ENT manifestations and thyroid, the allergic features it presents in the form of chronic rhinosinusitis, and due to the diffuse inflammation can involve the pharynx, hypopharynx, and Valdeir's ring, and where the patients frequently present with mass lesions in the neck. So their patients, due to the allergic manifestation, we have seen the eosinophils as well as high serum IgE. So based upon the location, we have the various different like the GPA, AGPA, sarcoma, and chronic infections like tuberculosis have to be considered upfront. Coming to the IgG related kidney disease, basically it causes plasma cell rich tubulointerstitial nephritis. And typical presentation of IgG4 is it presents as acute renal failure without proteinuria. And hypocomplementanemia is seen in around 50% of the cases. It actually indicates the disease relapse in the case of IgG4 related kidney disease. If you see this picture, you can see the multiple wedge-shaped opacities, which are actually being separated with the normal tissue these are actually clearly demarcated. This is one of the important feature of IgG4 related disease. The CT findings are actually slightly go towards IgG4 based upon the CT findings, and the distribution of the lesions are margins between the affected and unaffected area clearly demarcated. And the unique feature is that inflammatory cell infiltrate can actually go beyond the capsule, causing a rim-like lesion on the CT. So differential diagnosis usually include renal cell carcinoma, sarcoidosis, Sjogren's syndrome, SLE, which can usually present with tubulointerstitial nephritis. But the plasma cell, IgG4 staining, as well as the classical picture of CT should clinch the diagnosis of IgG4 related disease. Next is IgG4 related sclerosing cholangitis and autoimmune pancreatitis. We know that the classical presentation is obstructive jaundice, and it is very important to remember severe pain abdomen is very, very rare during the pancreatitis attack. So don't take this clinical symptom into picture and rule out pancreatitis. So this is very, very important. At the same time, 30% of patients usually present with the capsule-like rim around the pancreas in IgG4 related disease. And if you see this extra pancreatic bile duct stenosis, IgG4 related sclerosing cholangitis, we can see this extra pancreatic. That is, I told you in that MRCP picture, where the lower part of the common bile duct is actually involved in the case of IgG4 related cholangitis rather than the IHBRD. And almost all patients have autoimmune pancreatitis in the case of IgG4 sclerosing cholangitis. So these are the various differential diagnoses. So according to that area and the clinical presentation, we have to rule out various carcinomas. Like in the case of biliary, we have to rule out cholangiocarcinoma. Maybe this is possible only for biopsy and by the radiological picture. So if you see the differences between the PSC and IgG4-SC, how does both are sclerosing cholangitis, but how do you differentiate? One thing is that this primary scler has two peaks. It can occur in the younger as well as elderly. The serum IgG4 levels, they are actually elevated in IgG4-SC. However, they are non-specific and the other organs are involved. And here, if you see, this is the most important thing. Imaging of the biliary tree actually helps you in differentiating to somewhat in this type of cases. I am repeating this again. Long strictures, low bile duct strictures in MRCP in the imaging actually goes towards IgG4. If it is short strictures, see these are the short strictures, and these are actually present on within the liver, that is in the intrahepatic biliary radicals. Because the important differentiate because the treatment differs, because IgG4 classically improves with steroids. Next is IgG4 related periitis and iotitis. Basically targets three areas. One is periaortic area, periureteral area, and it can present as a plaque-like mass that broadly involves the retroperitoneum. When we say the retroperitoneal fibrosis, it is presentation the patient presents with poorly localized pain in the back, flanks, and lower limb swelling sometimes. So if you see the differential diagnosis based upon the location, the retroperitoneal lymphoma, sarcoma, and idiopathic retroperitoneal fibrosis are important DDs for IgG4. But how do you differentiate between IgG4 and idiopathic retroperitoneal fibrosis? There are some differences. One is male predominance is seen in IgG4 when compared to no sex prediletion in the case of idiopathic RPF. Multi-organ involvement diagnosis is common in case of IgG4, and it is actually the type is higher proliferation subtype. This actually helps in the management of the patient. Next is high recurrence is seen in the case of IgG4 RPF rather than idiopathic RPF. Coming to the iotitis, I already showed you infrarenal part of the aorta is commonly involved, and periititis is one of the common picture of IgG4 related disease. So differential diagnosis, we know that large vessel vasculitis should be taken into consideration. However, the other parts will help us. Suppose if only aorta is involved, we know that in large vessel vasculitis like Takay's arteritis, the usual CT iodogram picture is stenosis or occlusion of the involved arteries. But in the case of IgG4 we can see it is mostly of periiotitis, and various organs around that aorta are commonly involved. And abdomen gesture disease, I have shown you the DD where thoracic aorta is commonly involved in abdominal aorta. So cardiothoracic manifestations, and recently this coronary arteritis, they have seen that coronary arteritis can happen with IgG4 leading to coronary artery aneurysms or acute coronary syndrome, which are actually increasingly recurrent. Coming to the differential diagnosis based upon the location, lungs and mediation, we have to look for adenocarcinoma of the lung and inflammatory myofibrotic tumor. Coming to the diagnosis, clinical history and examination, serology, IgG4, tissue biopsy is the gold standard. Imaging based upon the local part.
अंगाचे बेळगावाचे
Hello.
Prasad, please mute everyone.
कसं नाव ते
PET-CT extended monitoring of the disease. So when we start talking about IgG4 levels, we know that greater than 2 times is slightly specific, but we should not go with only IgG4 levels. Normal value does not exclude IgG4 related disease. Around 30 to 40% can have normal value, and clinical relapse has been observed in early area around 10% with normal values. What are other causes? The other causes where IgG4, see PSC can have sometimes IgG4, raised IgG4 along with cholangiocarcinoma as well as pancreatic cancer. So don't go with only IgG4 levels. So this is the revised comprehensive diagnostic criteria for IgG4 related disease. So this is the new one which has come in 2020. What about the 2011 criteria? How does this criteria differ from 2011 criteria? If you see this has 3 items: item 1, item 2, and item 3. So in the first thing, if you see in the 2011 criteria, they have also included this single organ, that is lymph node swelling had been included, but in this has been omitted because of non-specific biopsy features. So that is one change. And the second change is basically this one. This is positivity. If you see the 2011 criteria is very rigid criteria where they expect that all the 3 features should be seen on the biopsy. But in this criteria, if 2 out of 3 are positive, it can be considered into the diagnostic criteria. These are the changes in 2011 criteria. Changes from 2011 criteria. So if a single organ is involved, we have separate criteria where organ specific criteria can be used. Coming to what about this clinical classification criteria? We know that diagnostic criteria for diagnosis, individual's patient approach. When it comes to classification, it is like a clinical trial approach. This is three-step approach. Entry criterion involves a clinical and radiological. Out of 1 by 11 typical organs have been taken or pathological evidence. Exclusion criteria is basically, if you see, what do they say is that we have to exclude these cases. Suppose, for example, if the patient is having fever, they should be excluded from IgG4. From like leukopenia and thrombocytopenia, which are very uncommon IgG4, they should not be taken in primarily as IgG4. In the same way, if you see these markers of macrophage or histiocytic disorder. So at this point of time, I want to say to the residents that please remember, as in our case, we have histiocytic positive markers. Even though we included the case, we have evaluated the case further. Always remember, this is a classification criteria. Classification criteria should not dictate your management. It is only to classify in clinical trials. So every patient has to be evaluated in your own way. So last is inclusion criteria where they have given weighted domains. That is, for everything they have scored points. According to them, if the score is greater than 20 points, it will be taken into the classification criteria. So other laboratory findings which are actually help in realizing whether IgG4-related disease is active or not, that is peripheral eosinophilia, increased ESRP, hypocomplementemia. It's one of the important laboratory finding which actually helps in recognizing the flare of IgG4-related, especially kidney involvement. So these are the four histopathology of IgG4. One is dense plasma lymphoplasma plasmacytic infiltration by IgG4. We know the ratio is also very important, and storiform fibrosis and obliterative phlebitis. Don't expect to see all the features in all the IgG4 related cases, because most of the times we can't get all the features in a single biopsy specimen. So based upon this, they have divided IgG4 patients into two categories. One is proliferative variety, and second is fibrotic variety. So here, if you see, proliferative variety is usually multi-organ affected, and these are the organs involved. And the importance in stratifying these patients as proliferative or fibrotic is because of the prognostication, the treatment response. If you see the biopsy in this patient, patient's biopsy shows excellent lymphoplasmacytic infiltrate with common general center is active, storiform fibrosis is present along with obliterative fibrosis occasionally seen. But in the case of the fibrotic variant, you can see the single organ involvement, like in the case of retroperitoneal fibrosis, where radial thyroiditis, where it's completely, most of the times it is fibrotic in nature. So all the other features of active disease are uncommon. So here we'll be having less response to the therapy. That is less robust than in proliferative, but good if initiated early. So these are the various subtypes. Coming to the management. So treatment basics as that till now we know that glucocorticoids are the first line therapy. So previously it used to be seen that traditionally wakeful watching has been followed in few cases in the past. But at this point of time, I want to tell you that you should actually individualize the patient. If the patient is 65 years old, patient is diabetic, you can't actually give only steroids and keep waiting for him to not to relapse. So definitely you should take a decision based upon your own level. So there are few conditions in IgG4 which requires urgent management. For example, iotitis, retroperitoneal fibrosis, where it can actually cause a reversible damage to the surrounding ureter, or it can actually involve the bladder also. So proximal biliary structures, where primary cholangitis can be a life-threatening complication if not attended early. Coming to the first line therapy, we know that glucocorticoids are the first line therapy. So back in 2009, 2008, when they had followed these protocols, one is Japanese protocol, another one is from Mayo Clinic. In Japanese protocol, they have started from 0.6 milligram per kg, and they have tapered over time, and they did not give any second line. At that point, they have seen that nearly around 25% of the patients had relapse. The difference between this and this is that they have actually continued the dose up to 3 years. In this Mayo Clinic, they started from 40 milligram per day for 4 weeks, followed by taper, and they used to offer all the therapies by the end of 11 weeks. So, but initially the patient will have a response because steroid will actually work in most of the cases. So more than 50% had relapse. So the thing is that it's always relapse with low cortical toxicity. Definitely, you should actually, personally saying, you should actually start with some second line immunosuppression whenever you start, because later on you can stop it if not required.
Dr.
Coming,
Prasanna, you have 5 minutes more to
yeah,
complete your lecture. Yeah.
I'll complete. Thank you. So when the other agents have been seen, this is the various DMARDs which have been tried. There's azathioprine, methotrexate, leflunomide. There are no great studies that randomized controlled trials about all these agents. Otherwise, they don't have any head-to-head trials between these agents. However, most of the agents work with relapses even on them. So then that is the need of new therapy, that is targeted therapy. CD20 anti-CD20 rituximab has been come into role. I'll not go into detail. So this is one trial. This is the prospect to open label trial where rituximab has been tried in about 30 patients. This is in this trial they have developed this index called as IgG4 responder index. Residents, please go and read this. So the results of the study, is they have shown that disease responses occurred in around 97% of the patients. However, there are some relapses. So what is the cause of this relapse? If you see this B cell development, we know that not all cells will have CD20 positivity. Some of the cells in the earlier development cell line and the long living plasma cells will not have CD20 positivity, where CD19 will be present in all the cells but not CD20. So there actually, this is the targeted therapies. If you see the naive B cell cell rituximab, ofatumumab, obinutuzumab act on CD20. The new therapeutic case which has been FDA approved is inebilizumab. There is target is CD19, and the other agent is obexelimab, where actually it prevents the interaction between CD19 and FcR gamma receptor 2b. And the other important agent is abatacept, where it actually blocks the interaction between CD80, 86, and CD28. And dupilumab is IL-4. So this is the trial which has been published in NEGM, inebilizumab. It's a trial called as Mitigate trial. It's very, very important. I'll not go into details. The participants are actually greater than 18 years. They followed the ACR criteria. 52 weeks of treatment has been taken into consideration. The mean age is around 58.2 years. And the important thing is 54.1% recurrent IgG4 disease have been included in this case. And inebilizumab was given at the dose of 300 milligrams IV on day 1, 15, and week 28, and they followed up at the week 52. The primary outcome they have seen is the disease flare was significantly very less in the case of patients with where inebilizumab has been used, and so the flare-free, treatment-free complete remission was 57% in the case of inebilizumab and compared 22% in the case of placebo at the end of 52 weeks. So inebilizumab decreased the risk of flares of IgG4-related disease and increased the likelihood of flare-free complete remission at the end of 1 year. So this is the just to summarize all the agents of target CD20 rituximab, CD19 inebilizumab. So here we can see the plasma cell target CD30 daratumumab, and here we have CD19 where the co-ligation has been prevented by obexelimab. So the other novel targets where T cells are, one is abatacept, and this is one of the important agent we have shown you in the pathophysiology SLAM F7 CD4 cytotoxic T cells along with interaction with where elotuzumab. This is the thing. This is plasma cell B cells along with we can see the engagement is SLAM F7 receptor where due to this elotuzumab acts on this. So still trials are going on. Let us hope that this also becomes successful. Thank you. Thank you so much.
Excellent lecture, Dr. Prasanna.
देवकुंडे येणार होती आज ते
Excellent lecture, Dr. Prasanna. I have few questions in the chat box.
Yeah,
So I'll go through the 2-3 questions. Dr. Nidish is asking, what is the utility of serum IgG4 levels in the diagnosis, monitoring, and predicting the relapse? Also, is asking about IgG4 levels. Do they normalize after giving steroids in all cases?
का पेशंट पहिला आहे
Hello. One is actually speaking. So the first question is, what about the levels of IgG4? IgG4 actually need not be elevated in all the cases. If it is normal also, the diagnosis can be made. After giving treatment, not in all the cases it will come to normal. It can be mildly elevated even after treatment, but it is not the sign of relapse. We have to look at other symptoms and other presentations also. What is the second question?
Second question he is asking, what does IgG4 levels normalize after steroids in all the cases, after steroid therapy?
Yeah, it can normalize, not in all the cases. Exceptions might be there, but I don't remember the percentages of that. But exactly IgG4 is actually a good steroid responsive disease when it is proliferative subtype.
Okay. Also, second question is, Dr. Ramya is asking, how do we evaluate for retroperitoneal fibrosis? Many a times the site of lesions being retroperitoneal is access would be difficult. And in such cases, do we rely on IgG4 levels where biopsy is not possible, or serum IgG4 levels where are negative? And what shall we do? What will be our approach in diagnosis?
एमआरआयचा हे चालू होतं आता Zoom meet.
So if I'm the person evaluating this case of retroperitoneal fibrosis, definitely the first thing which I
presentation.
Ma'am, please mute
MRA.
Hello, ma'am. Hello. Yeah. So retroperitoneal fibrosis, she is asking.
Yeah, definitely. The first thing I would follow is going with the imaging. The first thing, imaging, that is where exactly which organ is getting involved. First, I'll go with the treatment aspect. Then I'll think about the cause. Cause I have told you already. The idiopathic difference between idiopathic and this thing is that in the case of idiopathic retroperitoneal fibrosis, it is actually less treatment responsive. Treatment response is one of the things that has to be assessed. However, when I'll go and assess the other organ involvement. If other organs are involved, definitely I'll go in favor of IgG4 and go forward with the treatment.
Lecture somewhere. So, Dr. Kavyashree is asking, this is last question. How do
Hmm.
we decide when to stop maintenance rituximab in IgG4 related diseases?
Actually, there is a very good question. There are no clear-cut guidelines. To the patients, actually, in KGMU, we were treating nearly around 5 to 6 patients in of IgG4. Till now, we don't know when to stop the therapy, but have to closely follow them up. Actually, at least if the patient is rituximab, first increase as we follow in other diseases, we are following the same. Just decrease the dose, increase the dosing interval. That's how we follow, but there is no strict guidelines when to stop the therapy for IgG4 related disease.
Okay. Thank you, Dr. Prasanna, for this excellent lecture.
Thank you.
I hope everyone is clear with IgG4 related diseases. Thank you. So we'll meet again for the next MRA interface session in the month of March, third Sunday of March. Thank you. Thank you, everyone.